Hello guys, now we will discuss atrophy. This is the second lecture. Atrophy means definition, decrease in the size and number of the cell. So when both size and number of the cells are decreased, it is called atrophy. By what mechanism? By three mechanisms. Decrease in protein synthesis leads to decrease in the size of the cell, and second, ubiquitin proteasome degradation pathway, and third, autophagy. These both pathway, ubiquitin proteasome degradation pathway and autophagy, these are simply intracellular degradation pathway. Intracellular degradation pathway. Let's see how it works. Ubiquitin ligase, this is an enzyme, it activates and bind ubiquitin to the target protein. When ubiquitin bind to the target protein, degradation happen by two mechanisms. By the first mechanism, when ubiquitin bind to target protein, it simply activates proteasome. Proteasome is an organelle, and now degradation of ubiquitin plus target protein and atrophy take place. Or simply, when ubiquitin binds to the target protein, these are taken into a double membrane structure, and the double membrane structure is called autophagosome. And this autophagosome combined with the lysosome and degradation of protein take place. So simply, what is meant by atrophy? Atrophy means size and number of the cell both are decreased, and by three mechanisms: decrease in the protein synthesis, ubiquitin proteasome degradation pathway, and autophagy means self-eating. These three are the processes which leads to atrophy. So cell adaptation is physiological or pathologic. So I again and again emphasizing upon this point that it is both physiologic and pathologic. If somebody asks, give me an example of atrophy, and that is physiologic, so your answer would be during fetal development, loss of notochord and thyroglossal duct. This is a physiologic. If somebody asks from you, what give me an example of pathologic atrophy, so your answer must be simple: denervation atrophy. Denervation atrophy means this is a muscle and here is a nerve supply. When this nerve supply is shunt or degrade, it is simply by atrophy process. So now yesterday I have discussed this, that endometrial adenocarcinoma is associated with hyperplasia. But today I will also discuss that endometrial adenocarcinoma is also associated with atrophy. So how will you differentiate that endometrial adenocarcinoma is whether hyperplasia or atrophy? So yesterday I have discussed that type 1 endometrial adenocarcinoma is an example of hyperplasia, and endometrial adenocarcinoma type 2. Type 2 is an example of atrophy. And whether this is a where this will be treated or not, so it means it can be treated. So it is a good prognosis, and it cannot be treated, type 2, so poor prognosis. And both are precancerous lesion. This is very simple. So now let's move toward metaplasia. What is metaplasia? So metaplasia, simply, when one mature cell is replaced by another type of mature cell, means that one mature cell is replaced by another type of mature cell. It simply means that here is squamous cell present. What? Squamous cell present in the GI tract, like in esophagus. Simply, squamous cells are present. When these squamous cells are replaced by columnar cells, so this is also a mature cell, this is also a mature cell, and it replaces squamous cell, so we will call it metaplasia. One mature cell replaced by another type of mature cell, it is called metaplasia. By what mechanism? Cytokine or growth factor. Simply, in the tissue stem cell there is a reprogramming. Tissue stem cell, instead of generating one type of cell, they generate another type of cell, and it is called metaplasia. And if somebody asks, metaplasia is physiologic or pathologic, so your answer will again be both physiologic and pathologic. If somebody asks from you, give me an example, doctor, of physiologic metaplasia, so your answer will be in cervix, during menstruation, squamous metaplasia at squamocolumnar junction. Squamous metaplasia at squamocolumnar junction. The name means that the cell is replaced by that cell. It simply means that in the cervix normally columnar cells were present, and now instead of columnar cells, squamous cells are present. So we will call it squamous metaplasia. And somebody asked from you, the doc, give me the pathologic metaplasia example. So your answer will be whether epithelial pathologic or connective tissue. In connective tissue, there is a simple that during trauma, muscle within muscle bone are developed, which is called myositis. So bone within the muscle is called myositis, and it is an example of metaplasia, and it is simply a connective tissue metaplasia. If somebody asks from you epithelial tissue metaplasia, so your answer would be like during smoking. During smoking, in the respiratory tract, normally columnar stem cells are present. Now these columnar cells are reprogrammed in the bone marrow, and these columnar cells are replaced by squamous cell. So it names become squamous metaplasia. And by what type of mechanism the columnar cells are changed into squamous cell? So simply, it is the most common type of metaplasia of the respiratory tract, and it is due to the vitamin A deficiency or vitamin A excess. It must be remembered, clearly mentioned in a Robbin, that due to deficiency or excess of vitamin A. The second most important example is Barrett esophagus. Barrett esophagus is happened due to GERD, gastroesophageal reflux disease. Normally, squamous cells are present in the esophagus, and these squamous cells are replaced by columnar cells. And now these columnar cells having a mucin, a molecule in the vacuoles. So mucin in the vacuoles are simply called goblet cells. As we know that mucin in vacuoles are present in the small intestine. So this type of metaplasia is similarly to small intestinal metaplasia. So therefore it names becomes columnar metaplasia as squamous cells are replaced by columnar cell, and sixth name is intestinal metaplasia due to the goblet cells. And it is the hallmark of Barrett esophagus. And how will you differentiate whether it is where these are the goblet cells of the esophagus or the goblet cells of the small intestine? So simply you will take a stain. One stain is Alcian blue stain for the esophagus, and second is for intestinal goblet cells. You will take alkaline stain. The pH must be alkaline. So in alkaline pH, intestinal goblet cells will show their staining, and in pH 2 to 5, like acidic pH, goblet cells of the esophagus are shown its response. Risk of Barrett esophagus, it leads to adenocarcinoma of the esophagus. Simply metaplasia, then the process changes to dysplasia, and then it becomes carcinoma. But there always some exception, that after metaplasia always come dysplasia, and after dysplasia always come carcinoma. But there is a condition, like an apocrine metaplasia of the breast tissue, there is no risk of malignancy. Means in apocrine metaplasia, the dysplasia does not lead to carcinoma. You can see the picture. I will also give a clear PDF of these notes in the link. You can download those notes and also these pictures. Like in Barrett esophagus, you are showing squamous cell to columnar metaplasia. Alcian blue stain, we have discussed a Barrett's mucosa as Alcian blue stain differentiate intestinal goblet cells from the esophagus goblet cells. So after this we will cover lecture number 3, free radicals and cell injury. Thank you.